if it is a posteriorly projecting aneurysm, so step 1 is defining the ipsilateral A1, defining the ipsilateral A2, and cross the midline via the anterior communicating artery, define the ipsilateral contralateral A1, define the contralateral A2, and then separating the perforators from the superior aneurysmal neck, separating because here the perforators will be the aneurysm will be behind or sitting below the perforators. So it's important we separate the perforators from the superior aneurysmal neck. And then entering the interhemispheric fissure behind the ipsilateral A2. Okay, entering the interhemispheric fissure behind the ipsilateral A2 and separating the perforators from the inferior aneurysmal neck. From the superior aneurysmal neck, we dissect along here, and the inferior aneurysmal neck, we separate the perforators through this entering behind the ipsilateral A2. So thereby the superior and inferior part of the neck of the aneurysm is made free of the perforators, and then it is ready to be clipped. So this is how the clipping is appears for the various projections for the inferiorly projecting aneurysm, for the anteriorly projecting aneurysm, for the superior projections, and for the posterior projections. So which one of the following pathologies is most likely demonstrated by this angiogram? Yes? Answers? So whether it is an Acomm aneurysm or whether it is a middle cerebral artery aneurysm, can you give any guesses? Yes? Yes, answers? I need some feedback from you too. Okay. So no attempts. Okay, so I'll define this angiogram. So what you see here is the digital subtraction cerebral angiogram. So this is an anteroposterior view. So the various angiographic views and the pictures we have already discussed in the first session on the cerebral aneurysm. Hope you remember that. If not, you just kindly get back to me through my FB page whether what topics you would require. Because understanding of the cerebral angiogram, orienting yourself to the angiogram is very, very important in deciding the approach and in planning the surgical steps. Okay, so this is the anteroposterior view of the cerebral angiogram, the DSA picture. This is the anteroposterior view. So this is the internal carotid artery. Okay, the internal carotid artery is bifurcating into medial. The ICA is bifurcating into medial A1 ACA and lateral M1 MCA. Okay, so the ICA is bifurcating into medial M1 ACA, A1 ACA and lateral M1 MCA. The lateral M1 MCA is then bifurcating. This is the MCA bifurcation. Okay, the superior trunk of MCA, the inferior trunk of the MCA. So this is the superior trunk of MCA. This is the inferior trunk of MCA. The medial A1 ACA, then it is entering here, and then it continues as the A2 ACA distal to the anterior communicating artery. So this is here lies the anterior communicating artery, which is not very distinct. So you can also see that the A2, the contralateral A2 is seen arising from the ipsilateral A1 itself. So the appearance is like this. So this is one common anatomical variant which we see in anterior communicating artery aneurysm. So this is the aneurysm here. So what you see, the aneurysm is here. It's an inferiorly projecting aneurysm. So this is the aneurysm. So this is the A1 ACA, ipsilateral A1 ACA, which is then continuing as the ipsilateral A2 distal to the anterior communicating artery aneurysm. What you see here is both the A2 is seen arising from the ipsilateral A1. Okay, so this is an anatomical variant which is also called as the asymmetrical anterior communicating artery complex. So the aneurysms of the ACA, they typically form close to the anterior communicating artery complex. They constitute about 30% of all intracranial aneurysm and are considered as one of the most common types of aneurysms. they are frequently associated with anatomical variants. So these are the various variants which can be associated with anterior communicating artery. The standard thing is a symmetrical one, which we routinely see. So what we have seen here is an asymmetrical anterior communicating artery aneurysm. So you can compare this picture with this. So this is what I tried to show here. And then there's a fenestrated anterior communicating artery. So this anatomical variant also I will show up. This was the case which I operated for a dual aneurysm, the fenestrated anterior communicating artery. And then is the accessory anterior communicating artery, then accessory A2 ACA, then assigus ACA, where you will have a common A2 from which will supply to both the cerebral hemisphere, the medial part of the cerebral hemisphere, and then it is a bihemispheric ACA. So these are the various possible anterior communicating artery anatomical variants. So aneurysm often occur when one A1 segment is hypoplastic and the dominant A1 gives rise to the both A2s. In such case, the aneurysm arises at the level of the anterior communicating artery at the point where the dominant A1 segment bifurcates to give rise to both the right and left A2 segments. So the direction in which the dome of aneurysm points is determined by the course of the dominant A1 segment proximal to its junction with the anterior communicating artery. So the projection of the dome of the aneurysm, it is decided by the blood flow or the dominant of the dominant side of the A1. So that is what they are trying to say here. So the direction in which the dome of the aneurysm points is determined by the course of the dominant A1 segment proximal to its junction with the anterior communicating artery. So thus, these aneurysms, they usually point away from the dominant segment towards the opposite side because of the direction of the blood flow. So the approaches to the anterior communicating artery aneurysm must ensure that the anterior communicating artery and the adjacent recurrent artery of Huebner remains patent. Remember, during the anterior communicating artery, while you trace the ipsilateral A1 and the ipsilateral A2, the artery of recurrent artery of Huebner also accompanies along the superior border of the A1 ACA, A1 ACA. So there could be various origin of the recurrent artery of Huebner, but it is important that the recurrent artery of Huebner is patent and it is preserved while dissecting along the ipsilateral A1 and A2 ACA and along the anterior communicating artery. Because if the recurrent artery of Huebner is injured, we may get an entity what is called as fascio-brachiomonoplegia. It is called as fascio-brachiomonoplegia. So the anterior communicating artery gives rise to small perforating branches for the dorsal surface of the optic chiasm and suprachiasmatic area that perfuse the fornix, corpus callosum, and septal region. Occlusion of the anterior communicating artery may lead to personality disorders even if both A2 segments are perfused from the respective A1 segments. So that is why it is important we dissect the perforators from the anterior communicating artery, and the neck of the aneurysm is clearly defined, separated from the perforators, and then we clip the neck of the aneurysm. So the recurrent artery of Huebner, it arises variably. It can arise from the distal A1 or proximal A2 or the frontopolar branch of the ACA. So occlusion of the recurrent artery of Huebner may cause hemiparesis or aphasia, which is called as a fascio-brachiomonoplegia.